This is LiveWell Talk on lead extraction. I'm Dr. Dustin Arnold, Chief Medical Officer at Union Point Health, St. Luke's Hospital. Patients who have pacemakers, implantable defibrillators, and other devices which have leads or wires occasionally need to have those wires replaced or removed. This is a complex procedure and is done right here at St. Luke's Hospital. In fact, the only hospital in Cedar Rapids that performs lead extraction or lead removal. Returning to the podcast today is Dr. Talha Farid, an electrophysiologist with St. Luke's Heart Care Clinic, who is fellowship trained in this procedure and other skillful things in electrophysiology. Dr. Farid, welcome back.
Thank you very much.
Well, I was kind of clumsy in that introduction, it's a lot of in the weeds, so to speak, of electrophysiology. So maybe you could just tell us, what is a lead, what is a wire, pacemaker wire, and why do they have to be removed?
Right. So a lot of people who are having slow heart rate or heart rhythm issues end up needing what we call pacemakers or defibrillators. So we essentially have to put a wire into the heart, and that actually supplies electrical current in case of pacemakers. So it makes your heart beat. In case of defibrillators, it monitors your heart. If your heart goes out of rhythm, it shocks you. It brings you back. It's a life-saving device. In both these cases, these wires or leads remain in the body for a number of years, in some patients a few decades. So what happens is that as time progresses, there is fibrosis or scarring around these wires. So occasionally when there's infection in the body or infection in the device, infection in the lead, we have to take these devices out. But because of the scarring, taking it out is much more complicated than putting it in, and require additional training, required equipment, has to be done in the OR with CT surgery backup. So that's why taking it out is a lot more complicated than putting it in. Now, there are other reasons for which we have to take these devices out. The most common is obviously infection. But if there's a malfunctioning device, leads that's not working after working about 10 to 15 years, previously, the trend was that we would call, quote unquote, abandon the lead. So that means we would just leave that lead alone and just put another lead in. But now we know that the risk of infection is actually higher if we do that. So it's better in the long run for patients to extract those non-functional lead and put a new lead in. So there are a lot of patients who end up needing these procedures.
Yeah, that's my first question. Then are you able, let's go through the scenario. Had my pacemaker a long time ago. I got a couple abandoned leads. Let's say I have two of them on the left side.
That's
and for
correct.
whatever reason, I had to have my pacemaker moved to the right. They put the pacemaker in. They put two more leads to that pacemaker. Right. Can you take those two out? I mean, is there a time frame here or a lead that you're like, we can't take that out?
No, we can take them out at any time. Actually, it's better. Sooner we take out, the better.
Right. So before it scars down.
That is correct. So, people who actually do extractions, they don't like to leave leads behind. So if I have to move a pacemaker, I would actually take these leads out at the same time and put a new pacemaker on the right side. But most of EP physicians, they don't do extractions. So what they do is they leave them alone and put a new one in. But they can be taken out at any time. But the sooner we take out, the better it is.
That's fantastic for people.
Yeah.
Because as we were talking before the podcast, we were talking a little inside baseball. And I've seen patients that have old leads in there. Eventually you're going to run out of space.
That is correct. So, all of them go to, obviously SVC in the same vessel.
Yeah.
So after some time, you develop what SVC syndrome, and you cannot put any more leads in, obviously.
Right.
So that's one aspect to it. The second aspect is, let's say if you develop infection 20 years from now, the older lead is 20 years older than it was 20 years ago when you had to move the pacemaker in. So it would be more difficult to remove at that time with a high risk of complications. So the sooner we take them out, the lower risk the procedure is, with better outcomes and less complications.
Makes total sense.
Yeah.
But it is an option for someone that may have those old wires in there.
Absolutely. That's always an option.
Now, next question. How do you, at the level of the heart, how do you get them out of that?
So there are a few tools that we have to use.
Yeah,
obviously,
that's what we want to hear about.
Because of the scarring, we cannot, for putting it in, we just advance in the blood vessel and it just goes in the direction, and we give some curves and it goes to the heart. Taking it out, it doesn't come. So what you have to do, have to use special tools to cut the scar tissues around it. Now the tools depend on the type of tissue that's around the lead. Sometimes it's just the fibrous tissue or the scar, so we have to use laser to cut that tissue around, and we keep advancing that laser sheath up to the heart to free up the whole lead. In other cases, it's more calcium. Laser doesn't do a good job going through calcium, so we have to use mechanical tools, just like scissors, so it keeps cutting the calcium around bit by bit, and you have to take it all the way to the heart. And sometimes it's a combination of that, followed by we put, there's what we call snaring. We hold this lead from the bottom, from the groin, and we have to pull it down that way. So it depends. Every case is different. No two extractions are the same. And so there's always something different about every case.
It's like a box of chocolates. You really don't know what you're going to get when you get in there.
Well, I didn't think of it like that, but you're absolutely right.
Yeah, you can use that phrase if you want. We're not going to. So what's the recovery then? So this is this doesn't require open heart surgery.
It does not require open heart surgery. So we have a good collaboration with our CT surgery team. And because of the relatively high risk of the procedure, we do it with CT surgery backup. And the idea is, in case there is a complication, then CT surgery would have to step in and take care of it. But so far, we never had to do it. We have been doing it for about 3 years now here in St. Luke's, and we never had to have a CT surgery jump in to take care of things. But they're always available for backup if needed. Yeah.
Wow, fascinating. I've been in practice 27 years, and I can remember patients having to go up to the Mayo, 20, 23 years
correct.
ago for this procedure. So I'm a little bit more excited about this than others, just because I remember those cases.
Correct. That is correct.
Or an infected pacemaker.
Right.
If you're an elderly person, you had an infected pacemaker, it was a big deal. And there weren't a lot of options,
You're absolutely right.
And now you have the opportunity to do something for them that we didn't have 20 years ago.
Yeah, absolutely right. Infection, especially device-related, can be a big deal.
Yeah.
And for a lot of patients, it's like a death sentence. If you don't do extractions, there is no way to recover from it.
Right.
No amount of antibiotic is going to take care of it.
Right. Yeah. No, I've tried. I've had patients that we tried to do antibiotics.
Yes.
And you either that didn't work, or the integrity of the pacemaker quit working, or the lead because it was infected.
That's right. So now what we, if we have the initial signs of infection of the pacemaker, we learn gradually with time that treating with antibiotics and it's not going to take care of it.
Right.
So essentially what happens is the infection of endocarditis, goes up, risk of complication goes up. So the sooner you take them out, the better it is, and the sooner the patient recovers.
But we should, I'll allow you to give it, but the chance of getting a pacemaker lead infected is very low.
It's extremely low.
It's not something that happens all the time.
It's less so if we talk about from the procedure itself, from the pacemaker implant, it's less than 1%.
Oh, yeah.
And it's actually less than 0.5%.
Yeah.
So it's just so low that it doesn't happen. But sometimes there are other infections in the body, right? You have pneumonia, and now you have bacteremia, and now suddenly you have bacteria sitting on your lead and device. So a lot of these infections are actually secondary infections that happen years, sometimes decades after you had the pacemaker done.
Right.
Yeah.
That's correct.
Yeah.
Doesn't happen very often, but when you do see it, you remember those cases.
That is correct.
So you did this in your fellowship?
I did. Yes.
I'm guessing this is not part of a standard fellowship. This is something you did in addition.
It depends.
Not every pacemaker doctor can do this.
And that is correct. 2 reasons. A lot of places actually don't do pacemaker or lead extraction. So if you're training at a program where there's no extraction, you will never.
Have the opportunity.
That is correct.
Yeah, okay.
I did my EP fellowship at Emory, and it was a referral hub for extraction for all over. So we were exposed to a lot of extractions. I think I did about more than 50 extractions in my fellowship, and we extracted more than 150 leads or so. So I was very comfortable doing it when I actually joined. And the funny thing is, the first extraction I did on my first day of procedure here. It was a patient that were getting ready to be transferred to university to get the extraction done. It was my first procedure day, and I said, we can just do it here. And they're like, "You're sure it's your first procedure day?" I said it'd be okay. So, but everything went okay. But yeah, those are rewarding cases.
Well, you're a talented man, and we're glad you're here. Remind the listeners, what other procedures does an electrophysiologist do?
It's a long list, but essentially we divide our procedure into two categories. One is the ablation procedures, where there's an abnormal heart rhythm and you have to go into the heart to take care of those arrhythmias. Essentially, it comes under the umbrella of what we call ablations. So atrial fibrillation ablations, SVT ablations, atrial tachycardia ablations. Then you have abnormal heart rhythm of ventricle. So ventricular tachycardia ablation or the PVC ablation. These are some of the ablations that we do. Then the second group is what we call devices: pacemakers, defibrillators, bi-V ICD or bi-V pacemaker implants, leadless pacemaker implants. Now we are coming with leadless atrial pacemaker implants. That's going to be on the horizon soon. And then obviously extraction.
It's fascinating. I've always enjoyed electrophysiology. I've always been fascinated by the things that can be accomplished, and it's exciting.
That is correct, but for a lot of people, it's like a black box. There's some people doing something in the corner we don't really know.
Oh, let me make it clear. It's still a mystery to me. It's still a mystery, but I just find it exciting.
Right.
Well, Dr. Farid, thank you again for joining me. It's always nice to have you on the podcast. Once again, this is Dr. Talha Farid, electrophysiologist with St. Luke's Heart Care Clinic. To learn more about heart care services, visit unitypoint.org/CR-HEART. That is unitypoint.org/CR-HEART. Thank you for listening to LiveWell Talk On. If you enjoyed this episode, don't forget to subscribe. And if you want to spread the word, please give us a 5-star review and tell your family, friends, neighbors, strangers about our podcast. We're available on Apple Podcasts, Spotify, Pandora, or wherever you get your podcast. Until next time, be well.